Good evening, good afternoon. I don't even know whether it's evening or afternoon, but welcome. It's evening, eh? Welcome again to this last session of yet another exciting day. Personally, myself, I'm very happy that there are no protocols to observe here. We'll just go ahead and get into this exciting session which we have, where we'll be discussing the next generation commodities and products around HIV and also reproductive health products. Now, with me, it's also very exciting to have a young man close to me. And this speaks again to the importance of this World Conference. Nyeko here is from South Africa. He's been one of these young men who has been leading the movement in terms of HIV/AIDS for young people. He's also been leading around issues to do with treatment advocacy. He's been also working around the sexual and reproductive health, including rights, which I thought some of the people may not mention here. So he's been in the forefront of that and also using the youth media literacy as well. So Nico, please introduce this session. Then afterwards, I will introduce the first speaker. Thank you.
Thanks so much, Prof. Molenga. Greetings, everyone. I hope you are still in good health and still in good learning vibes, since this is the last session of the day. And then allow me to unpack the pillars and the importance of Session 8, Next Generation Commodities and Products for HIV and SRHR. So we will be updating and sensitizing adolescents with SRHR and HIV future products in the pipeline, clinical updates of the products, installing the benefits of having future products, and the importance of being ready for the rollout and access of these products. So I will then give it back to Prof. Molenga to introduce the first key presentation.
Thank you, Nyeko. The next presenter is a close friend of mine, and it's a privilege, François, to share the platform with you for a long, long time. Someone who many of the people who have attended these conferences know. François is a professor from University of Wits, and yesterday he was giving a lecture until 1 a.m. His inaugural lecture as professor, so congratulations, François. And he was on time to make it that at least he's able to speak to us. And François has been one of the leaders in the HIV program, especially around ARV optimization. I think some of you know some of the works he has done, making sure that we are able to get drugs which are safe. He has been very actively involved in making sure that dolutegravir has its place in the guidelines, and he works with WHO, UNAIDS, and many, many other bodies. François, over to you, and welcome again.
Thanks, everybody, and thanks so much for the invitation. It's so lovely to be here and to hear such a spirited and animated discussion. It was great actually to be here this morning and just to see what kind of makeup of the audience it is, because it allows me just to pitch the talk. I've titled it Next Year, Next Decade, and it was interesting listening to Linda Gale now saying that you discussed it 7 years ago, and it's important for us to understand that these long-acting antiretrovirals are not here, and they're several years away, and they may well be 10 or 15 years away at the rate we're going at the moment. So I just want to talk about why that is and the development of them. And I just also want to talk about some quite simple concepts, because even I did not know this stuff. When I was putting this lecture together, it's a variant of one I did a couple of weeks ago. I don't think I quite understood what this is. And firstly, the term long-acting is a very loose term, but generally it means anything lasting more than a week. And it's not just injectables, it can also be things you swallow. It's things you implant. You can actually take it in forms of even patches and things like that. So these things just last a long time. You can take it, as I said, orally, intramuscularly. It can be as a subcutaneous injection just under the skin, or it can be implantable. So it's very similar to, in many ways, to contraception. The current antiretrovirals, the ones we use for the treatment of HIV, and the ones we use for PrEP, the currently widely used ones, are all dosed orally as tablets, conventional tablets. We may be able to decrease the doses of some of them, the treatment ones, to maybe 3 or 4 times a week, just because of the once you've suppressed your virus. But by and large, that's generally the paradigm that we're using. So what are we talking about practically when we talk about long-acting? It's very important that we understand that the number of drugs we're talking about is actually very, very small at the moment. There are only 3 registered formulations. And that actually shocked me when I had to get my head around that, because the way people talk about long-actings, we've been talking about long-actings for over a decade now. There are only 3. And they're quite specific. We're talking about cabotegravir, which is the hot drug of the moment, for PrEP. Now, cabotegravir is dosed for PrEP every 2 months. There is a little bit of work hoping that we can get to 3 monthly, which would help us a lot. And that's given as a muscular injection. Again, very similar to many of the contraception formulations. We can use cabotegravir for treatment with another, quite an old drug called rilpivirine. This injection is given as 2 separate injections. And again, it's important for us to get our heads around this, because you must remember, in our African situation, imagine getting your injections in a rural clinic. These are 2 separate injections in 2 separate places in your bum, okay? They are 2 different sites. The rilpivirine injection needs a cold chain at this point, and it's quite a painful injection, the rilpivirine one. The cabotegravir one is less painful. They tend to get less painful with time. The first one is pretty painful, the next one less painful, and so on and so on. And you can't give it to the hands of an untrained healthcare worker. You also can't self-administer it at this point. There is work being done to try to get it to self-administer. And at the moment, the drugs are pretty expensive. It's much more expensive than oral therapy. There's another drug called lenacapavir, which is made by a different company, and unfortunately this is important because of the politics between the various companies. And this is given as a subcutaneous injection, usually into your tummy, just around your belly button. And it's used at this point only for treatment. It's been explored in some very big studies and looks very promising for prevention, and you must watch this space. But it's used only for treatment-experienced patients, patients with lots of drug resistance. And there are actually very few of those patients in our context that would be eligible. And certainly my country in South Africa, which is a very large program, we don't actually use this drug because we have so many other drugs that we can use. And you use it with daily tablets. So it's not really that useful, which is why we don't use it in South Africa. We've got a couple of drugs in the pipeline. There's a drug called islatravir. Unfortunately, this drug was being used as an implant for prevention. There was some toxicity associated with it 2 years ago, which means that it's no longer in development for prevention. There was some excitement that we might even be able to use it for long-acting for treatment. But it got dropped because of this. It is being used as a daily tablet, and there is an idea that we could use it. It's been tested at the moment as a weekly tablet with lenacapavir. So 6 monthly subcutaneous injection and a weekly tablet, which is something we've never done before. So you must think for yourself, if you had HIV, would you prefer to take a daily tablet every day? It's quite simple. Or would you come in for a 6 monthly injection below your skin here and take a weekly tablet maybe every Sunday? I don't know. I don't know what I would prefer if it was me. The studies that are available for this will only be in the next 1 to 2 months. And it's not clear to me that whether this is something we would want or would need or would be supported. There are lots of other compounds being explored at the moment, but even if they make their way through the systems, it's only 2 or 3 years before it gets reported. There's the usual stuff. We're going to need pregnancy data. We're going to need all sorts of other data. So it's maybe 6, 7, 8, 10 years before these compounds are actually available. Why is everyone so excited about long-actings? Now, most of you will get this like that. And I think it's been interesting for me because healthcare workers often don't get it, is that patients absolutely love this stuff. And that's despite it being painful injections. We've been using these drugs in our clinic for a couple of years now in various studies, including a large one with Sissy Ketcher from Uganda. And people tell me men don't like injections. I tell you, men love these injections. Adolescents love these injections. Everyone loves these injections. People prefer this over taking oral tablets, certainly in other studies that we've been doing. There's all the issues around stigma, the issues around carrying these tablets, being reminded every day of your HIV status for treatment. For prevention, we've had really good results in the studies that have been done in the 084 study in South Africa. So, I think patients have leapt forward ahead of their healthcare workers in terms of embracing this stuff. There are some operational questions. It's all very well to say the patients love this stuff, but I don't know, certainly in South Africa, where we've managed to get the tablets out into the communities, where we distribute them in the pharmacies close to their homes, will they love it as much if they have to come back every 2 months? We distribute the tablets to them every 3, sometimes every 6 months when we're really good at our jobs. Will they like coming back to get 2 injections every 2 months, rather than just getting the tablets distributed to them every 3 or every 6 months? I'm not so sure. But we're getting these new drugs coming. So if we're lucky and we get like tablets, perhaps that we give you once every week, or tablets even once a month. Can you imagine being given like 6 tablets to take once a month, or getting an implant that you take once every year for your treatment? It really is transformative, and you can imagine why people are so excited. And it's not just HIV that's excited. We're looking at it for hepatitis C. We're looking at it even for TB. There's a whole channel of drugs that are starting to look at these new technologies to start making drugs last longer and longer. And I think over the next 10 years, things are going to transform dramatically. In some ways, in places like hepatitis C, they're even more advanced than HIV. HIV is taking a long time to move forward with the studies that are taking these drugs forward. We've had a lot of problems with adherence in certain areas of HIV. One of them has been with PrEP. And that's why the 083 and 084 and the cabotegravir PrEP studies have been so exciting, because we've managed to get on top of some of these adherence challenges. There are areas in treatment, and particularly amongst adolescents, where treatment has been a real issue. And I've seen some of the discussions coming up here over the last day that I've been here. And I think that's one area where cabotegravir in particular, in combination with some of these drugs, might be very useful. And we've been having some discussions here. There's also people who have chaotic lives, and this happens in adults. People they can make the appointment, but they can't take the tablet every day. And we see this particularly in drug-using communities, people who would benefit from coming in, getting the jab there and then getting on for the next 2 months, and they'll see you in 2 months' time. And perhaps those are communities that could be prioritized for these interventions. And we've seen some success in both rich countries and in low and middle-income countries with this approach. There's some big thorns out there. There's all the usual politics of drug companies and intellectual property issues. We've had some real issues with getting access to cabotegravir. And it's unclear to me why there's been such a big issue. But we've known that cabotegravir works for a long time, but we're still battling to get access to the drug for operational drugs, for operational studies. We are talking to big companies like Gilead around getting access to lenacapavir there, and we're still going to need those drugs for the various operational studies and for how to actually use it in our context. There's a lot of things around cost, and those things are going forward, and there's a lot of modeling work that's been done. The medicines patent pool is getting involved. There's a lot of advocacy that is being done, possibly not nearly enough, and it's not coordinated. I'm going to talk about it in a moment. The generic companies are getting involved very late in the game. Women are still not prioritized enough. We're very lucky to have the lenacapavir and cabotegravir PrEP studies, because we're getting lots of pregnancy data from that. But for the other drugs, we're going to have precious little data on women, because these companies always test it on gay white men in the north before they come down here and then do natural history experiments in the process. There's real issues around resistance, and I've just come from the resistance conference, Linda Gale and I, and there were real breakthroughs on the rilpivirine cabotegravir combination. This is not an ideal combination for any setting. And these were breakthrough combination breakthroughs in rich countries with very, very high, well-trained healthcare workers with lots and lots of resources. In our settings, that's a real concern. And I think it's something we're going to have to talk about when we start rolling out these combinations in populations who don't have the support that they have. One of the things I do want to talk about, though, is coordination. And I think cabotegravir is a very good example in getting it through. And I was part of the dolutegravir introduction, as you heard from Lloyd, and it was coordinated. It wasn't perfect, but we worked together as an international community to get dolutegravir through the door. And I'm proud to say that it came through the door. It could have gone quicker, certainly in South Africa, but the rest of the world managed to get, certainly Africa and Asia managed to get it through the door. But we're not seeing that with the injectables, and we're not seeing that with cabotegravir. We're seeing the researchers almost like did their research, and they were like, oh, we got a really good result, now what? No one planned for success. We still are years and years away from seeing cabotegravir for PrEP being implemented in any form, even in rich countries. There's hardly any of it going out there. We were told in the Brisbane conference that there'll be a small amount made available in 2007. You know, we need hundreds of millions of people to be on this drug by 2007. It looks like they're going to be a few thousand. And again, it's just like no one planned for this to actually be successful. We're seeing PrEP people going ahead, doing their own thing. The treatment people, again, they're going to need tens of millions of people to be on this drug soon. And there's no coordination around that. And what does that mean for volumes and for dealing with generic companies? The implementation researchers, Linda Gale and myself, just two of them, are having to beg for enough drug to actually do studies to actually show how we do this stuff in our context, in low and middle income countries. How do you do it in primary healthcare clinics? You know, anyone can make it happen in a clinical trials unit. But how do we do it where the cold chains are not working, where staff are not going to be able to, are in busy clinics and with long queues? The generic companies have only just been engaged, and it takes years for them to buy the equipment. Many of them don't look like they really want to do this. And it's difficult for me to understand, is like, why was there no one thinking about this going forward, that the generic companies would have to be one of the ones part of the process in all of this? There's no clear coordination with guidelines. Certainly in my country, it's like no one at the government level is really like thinking about this in a joined up way between PrEP and with treatment. And there's no clear coordination until very recently with the major donors and the major funders of treatment programs. There's no one person who's leading all of this. And that we did have with dolutegravir. We had everyone in the room together. It was difficult. It wasn't perfect, but it all happened. And it took a few years. And we're not seeing that with the long-acting injectables. But I think just to end up, the major challenges are going to be systemic. We've got a very complex health system challenge. We're introducing these injections into health systems that don't like complexity. You have to ask yourself about taking a trained nurse to give 2 different injections to selected patients in primary health care is going to be hard. We had difficulty enough in the old days giving efavirenz and nevirapine to and this is where I think it is going to be important for us to work out what we're going to do here. PrEP has actually been a failure across the world. Outside of Paris and San Francisco and a few selected verticalized programs, it really hasn't worked. And I think we need to ask some harsh questions about how we're going to make this work. It doesn't mean we can't. It just means we mustn't just mouth rhetoric about how we're going to make this work this time. And maybe cabotegravir is the drug that is going to help us get this right. And there are reasons I think that we could make it. We do have time, and it's not good news that we have time. It's because everyone's been sitting on their hands around this. But we probably have 4 or 5 years before we're going to have mass access to injectable cabotegravir at scale. And during that time, we're really going to have to learn very, very quickly how to use these drugs. I think that demonstration projects for PrEP around cabotegravir, even if it's not the perfect drug, start learning how we're going to administer this. And I think the adolescent communities are certainly great places because they're complicated communities that we can start looking at. And then the treatments. And again, I think adolescents should probably be one of the priority communities that we can start testing these in. Pablo and I have been talking for the last year about how we can start doing demo projects in these groups. And I think that we can start saying that this. So we have this time. We need to get ahead of the curve in terms of advocacy and start looking at these IP issues, start questioning why this thing is proving so difficult when we've had actually quite a good relationship with many of the originator companies in terms of getting access to these drugs. Why is it proving so hard with these long-acting injectables? And start working like an international community like in the old days that we did have, and asking for the transparency that's been lacking around these long-actings. Anticipating that some of the drug companies that we've worked with in the past are not going to be the one developing them. There's a whole lot of companies making drugs that we haven't worked with traditionally and may not understand the way we've worked with as a community in the past. Keep your eyes on the safety studies. They'll keep testing this on white men going forward until somebody like shouts at them loud enough. And we will not get the pregnancy data that we need and the data on women that we need to get this to scale it in our communities. And then think how guidelines should approach this. And finally, just learn the operational issues, because that's going to be the Achilles heel. We could have cabotegravir, lenacapavir available tomorrow at mass scale at no cost, and we would have no idea how to do this. No one would get the drug, because that's the stuff that is really hard, is how to get the drugs into our community practically and provide it. And I think those are the lessons that, the unsexy stuff. It's all very well to go and run big studies that show the stuff works. The really operational studies are where the rubber hits the road, and that's the stuff we must be thinking about, is how do we engage with our ministries of health? How do we talk to the people on the ground, the healthcare workers and the communities, and make sure that they're enthusiastic when the stuff hits. Make sure that we're not sitting having the same conversation in 10 years' time. Thanks very much.
Thanks so much, Prof. Venter, for the insightful presentation. I hope you are preparing your questions for the key presentations. And then allow me to introduce Wawira Nyagah from AVAC, all the way from Kenya, under the topic Bridging the Gap for Adolescents, Enhancing Access to SRH products and HIV prevention. Wawira directs AVAC's product introduction and access program. Wawira's area of expertise is diverse and includes marketing, market shaping, health communication, and marketing, strategy designing, facilitating, and new business developments. Wawira has solid experience spanning over 17 years in strategic design and implementation of development and public health programs. All the best, Wawira.
Thank you so much, and I'm very honored to share this podium with two very respected professors and a young person that is really passionate about ensuring that we are addressing the access issues. So really honored, and thank you, Prof, for starting that conversation. And my presentation, I'm going to be focusing on how best we can bridge the gap for adolescents to enhance that and make sure that they access these products for HIV and SRH. So I'll be focusing on three key things. What needs to happen on the product, then what needs to happen about programs, and what do we need to do about the beneficiaries. I will not touch on this because I think a lot of speakers that came before me really demonstrated there's a need, both for HIV and for family planning. And what we know is that the people that have unmet need for HIV prevention also have the same need for FP. Now, when we started the HIV prevention interventions, we did not start on a very good footing. And we made a few mistakes. One of them is that we led prevention with products. So we thought about how to develop products, but we did not think about how they're going to be delivered or the people that we're making these products for. Then there was a whole rush about designing around test and treat, and there were lots of targets, so a lot of people focused on that. And we always assumed that it's a one-size-fits-all, and the other thing is that the way we started HIV programming, we started with the negative and long-term, effects of HIV. So that was a very scary thing for the people that saw the initial campaigns for HIV. But and I think we can attest and say that part of the stigma that surrounds HIV was born out of that. So moving forward, we've been trying to learn in terms of what we could do differently, and to ensure that we are engaging adolescents and young people more effectively. So one of the things that we've learned is that we need to think relevance, because adolescents usually and young people undermine their risk. It's not a big deal, and I think all of us in this room that are young can agree with me. And then we have to design, for habit, not adoption. Adolescents are focused on relationship goals, and then the other thing we know is that we need to address their needs, not demographics. accepting and acknowledging that each young person has different needs. And then we have to think about ecosystems, not interventions, and we have to think about options, not preferences. So, our counterparts on the other side of family planning have also been doing something different to ensure that they are, able to deliver these services to the young people. And some of the interventions that have been found to work really well, and I have borrowed this from one of the programs that is really, really trying to, address issues for young people. So what we've learned is interventions that lead with girls' aspirations are much more successful. So what do the girls need? They want to be optimistic, they're thinking about positive self-esteem, they're thinking about self-care. So when we design our programs around that, they are more successful. And then the other thing is we need to address harmful gender norms, because we know that these have been a big, big impediment for uptake of SRH products and services. And for us to be successful in this regard, we need to work with the influencers in the community. I'm talking about partners, family, and the community leaders. And then we have to make sure that we have efforts, or put efforts in place to, to support continuation. And this should be tailored, on each and every young person's experience with these products. Then, so, when we think about the products that we are talking about, and on that presentation, I've tried to look at what we have for both, fields. The contraceptive field is way, way ahead, and they have different types of, products that are delivered through different mechanisms. And it's just right now that we are trying to catch up in the HIV sector. I will not dwell on this because Prof talked about some of the products, but then the key takeout from this slide is that in the next 4 to 5 years, we might have about, 4 products, if all goes well. That is oral PrEP, the vaginal ring, cup for PrEP, and we have some additional products that are coming up pretty fast. We have the dwarf prevention pill that is going to help people prevent both pregnancies and HIV. And even more exciting, people are really putting an effort. And I wanted just to spotlight what USAID is focusing on, but these products are not even anywhere near. They are trying to design products that are going to explore different delivery mechanisms, and then they have different durations, and also provide an option for multi-purpose use. So when we think about oral PrEP, and I think I've had people talk about the failures of oral PrEP, and they're not wrong. Since oral PrEP was introduced, so far we've only managed to initiate 4.5 people. While that is a significant progress, it falls way behind the UN targets for 2020, which was about 3 million. We achieved that about, I think, 2 years later. That means there's some work that needs to be done. Then I wanted to spend a little bit of time on this slide, because from this slide, what I'm trying to share is what we have in the market right now. That is the cup for PrEP, or whatever is coming to market soon. Cup for PrEP, the DVR. How far are we from ensuring that it gets the people that could benefit from using it? So far, cup for PrEP has been approved in 5 African countries. That is Botswana, Malawi, South Africa, Zambia, and Zimbabwe. And by extension, it should be authorized in Eswatini and Lesotho under South Africa approval. And we have some pending, regulatory approvals in a couple of countries in Kenya, Mozambique, Namibia, Rwanda, and a couple of them. The question is, what needs to be done to fast track these, regulatory approvals at the country level? That's an opportunity for advocacy. Then there are 20 CAB implementation studies planned across Africa, and the question we are asking, in all those implementation studies, are we answering the right questions? So, then, DVR has been approved in 7 Africa countries, and we're also waiting for others to be approved. Question is, again, what can we do to fast track that, approval? And then there are also 11 DVR implementation studies planned for Africa. And again, are we asking the right questions? Are we covering the right geographies? And are all the populations that we need to answer questions on covered? Now, shifting gears to contraceptives. This is a place that has been thriving, and we have a number of products. And I'm sure a lot of us in this room are very, very familiar with the ones on the left, the classics. These have been in the market, especially the African market, for a while. And then we have slightly newer products, and some of them are available, but not probably in all the countries. Then we have the upcoming products, very interesting products. We have a ring that is supposed to be 1 year. And then I talked about the dual prevention pill that just received the bioequivalence approval. And what that means is because it combines 2 products, oral contraceptive and oral PrEP, when it's put together, does it work the same way as when it's taken separately? Even more interesting, so what's coming or what's cooking within the family planning sector? So there is a slight shift, and what they are looking at is developing products that are biodegradable, and this ranges from patches to microneedles to implants. And then they're also looking at longer acting injectables, and they're looking at a 6-month injection. And also there's a lot of interest on the multi-purpose products that can prevent pregnancy plus HIV stroke, either herpes or HPV. And again, really interesting is the male contraceptives that are in the cooking. And some of these will be injections or gels. So I see that even that market is trying to cater for the needs for different users. Now, when we think about developing these products, there are a couple of things that we need to think about. When we're talking about the products, a lot of effort is put to make sure that they are efficacious, or the efficacy works, and we are addressing the issue of dosing and duration, reversibility, side effects, and the mode of delivery. And what we need to think about is also ensuring that we are engaging with the national decision makers that design the program, just to make sure that the service delivery or the channels are ready for these products. Does it mean that, what does it mean in terms of the cost of the product and also of the program? Does it require training for the healthcare providers? And how do we need to start thinking about demand generation? And then when it comes to people, we need to think and ensure that we are engaging the end users way in advance. We may have failed, but then with the products that are way up the pipeline, there are some efforts to really ensure that they are getting input from the end users way in advance. And again, it's never just about the biomedical. For impact, we must combine and address biomedical, behavioral, and structural. And I think we've talked much about that. And finally, and very, very important, especially in this room, we really, really need community-led advocacy to ensure that we are pushing for prioritization of choice, both for HIV and SRH. And I think Prof also, closed with the same remarks. Now, I just wanted to spotlight one of the latest, interventions in that regard. And the Africa Women HIV Prevention Community Accountability Board, last month, they launched the HIV Prevention Choice Manifesto. And this marks a very historic milestone in the power of the community-led leadership and prioritization of choice in HIV prevention. And this really comes at a very opportune time when political will and financial investments are critical to deliver new prevention options, such as CAB. And I think we've talked about, some of the issues that are needing to be addressed. And with that, I wish to thank all of you I want to leave time for more questions. The presentation is a bit heavy, but I think we are going to make it available for the participants if you need it. And we've included a number of resources, so if you just need to understand, you can go into those. And I thank the organizing committee and all our partners that we work with to collect and share all this information. Thank you.
Thank you so much to our two presenters. We now go into a session for Q&A for those that have joined online. You can see even that there will be questions which you can read on the iPads. Then would like to take a number of questions for the two of them before we go into the abstract presentation. Wonderful, wonderful presentations which have been done. We can start with one.
Thank you so much. Again, all the presenters, it was actually a good presentation, well articulated. And also my excitement is because the issue of DSD, which is differentiated service delivery, as well as one size cannot fit. The service that might work best for me cannot work best for my colleague. So, seeing your presentations, all the research, and whatever that was done to make sure that we're coming to the to that point of having multiple interventions that young people can choose which one works for them. I think that one is very phenomenal, I must acknowledge. But my question goes to the last presenter who are presented on the several ways of HIV prevention. Some of those ways are way too expensive. And I understand in Malawi we had to include vaginal ring, the DVR, in Global Fund so that we can at least pilot in Malawi, because looking at the cost and everything that surrounds it, we feel that adolescent girls and young women cannot afford it. So I just wanted to find out how best are you making sure that you are addressing the issues of the cost so that young people can access it and use all those interventions. Thank you.
We call number 2 and make it short and straightforward your question, please.
Okay, thank you very much. My name is Ford from here, Zambia. So I don't have a question like for the panelists. I only have a contribution. So looking at the presentation that was given, so my contribution is to increase the reduction in HIV transmission. There is need to involve people living with HIV. Because if we leave out people living with HIV, let me say us people living with HIV, if we are left out in the issues of prevention, HIV prevention, then I think it will be very difficult for us to achieve that goal. The reason being is we have the best experience when it comes to HIV, the effects, and how it has affected us, our lives, our childhoods, and everything that we've passed through it. And we are the best people who can explain better and help each other as our fellow peers. And on the issue of, I saw something very interesting that really has made me happy is the issue of, I've seen something, the issue of the male contraceptive, which is the injection, the injectable one. So I'm trying to, like my colleague is from saying, I'm trying to also make an appeal to say if these injectable contraceptives for males come in, would really appreciate it if it would be very easily accessible, because our young girls, young ladies out there, most of them are refusing to access these contraceptives because they're having these misconceptions, and there is need for more dissemination of the information. So we really would love it to come early as men. Speaking on behalf of the men in the house, you know, our partners will be taking on behalf of our partners. Thank you.
Three. Then back to two there. There is another pending question.
Thank you. It's a question to Prof. Venter. Just to expand a little bit on why the CAB rilpivirine might have difficulties in our region apropos resistance. I think if you could just explain, I think there'll be interest in the room.
We can get the last question.
Very quick, also for François, Pablo Rojo from Spain. So François, what can the community do to improve the access or at least to make advocacy for injectables? Thank you.
Thank you. We start with Wawira. The question on how do we address the costs?
That's a tricky one because there are so many things to consider, and anytime I've sat in meetings where costs has been discussed, this has been a very sensitive discussion because on one hand, there's the manufacturer or the product developer that is looking at the cost of that. But basically, what we can do, there are two things. So at the global level, what we do is convene meetings with the key players in terms of who do we need to involve to have those conversations in terms of what might be done to try and negotiate the price of some of those products. And that's where we bring together the donors, some of the implementing partners, and also the product developers. At the community level, I think there is a real opportunity whereby you can do advocacy and really advocate for, fair prices. The community has a voice, and I think we can leverage that. And what we can do is just to ensure that you have the right information so that, as I think we heard yesterday, we can have evidence-based programming and advocacy. So, yeah, thanks.
François?
Thanks. Two great questions, actually. So Linda Gale's question is what are the problems with cabotegravir rilpivirine in our region? And there are two major problems. There's a lot of background efavirenz NNRTI resistance in our region, and the Achilles heel is rilpivirine, it appears, although there was one case, our case actually, which broke through actually on the integrase inhibitor. It does appear that this combination is not as strong as we initially thought it was. Having said that, it still appears it has a role, particularly for these patients who come in regularly for their visits and who have no other options. And adolescents, in some cases, are, the ones who come for every visit, but you're just not able to take the tablets every day. That might be where we can use it, but it's not ideal. And there will be new drug combinations coming in the future, and I'll talk about that in relation to Pablo's question. The second thing is, it actually makes viral load monitoring even more important, and we have not done a great job with getting viral load monitoring out there, even after 15 years of advocacy. And it's, outside of South Africa, Namibia, Botswana, and the key major central cities in Africa, we all want a villain, and there are villains in this piece. And everyone's like, ViiV is a problem. ViiV must give us this drug. ViiV must drop its patents. ViiV could give every generic company in the world the patent tomorrow, hand it over, and we would be no closer to getting this drug into the field. And the problem with it is that we need the researchers to be more coordinated. We need the governments to be more coordinated. We need WHO and the guidelines people to come to the table. We need the people working on prevention and treatment to be more coordinated. We need everybody to do this together as a team. It is not just about one single drug company. It's not about the originators. It's about everybody doing this to get us to a point where we have treatment and prevention, long-actings in the field. We are really going to need a coordinated. And you asked, what does the community need to do? you know, you can rage at the drug companies, and we need to be raging at the drug companies, but if that's all you do, we're not going to be any closer in 10 years' time. It's actually quite easy to rage at the drug companies, because, like I said, we all need a villain, and they traditionally have been an easy villain to rage at. The problem here is a lack of coordination and vision as to what we're trying to achieve. And what we're trying to achieve is safe, affordable, accessible combinations for our region. And that's going to need to come from an international group of people bringing everyone into the room together. And I think that's what we need to be asking, communities to be asking, is an accountable, and that's probably a combination of the major donors, WHO, people coming together and saying, this is the agenda that we need to go, and these are all the actors that are going to be, which includes the community and include the activists. It's going to definitely need to include the big originators, the generic companies, the researchers, all those people to be in the room together. But to start doing this in a coordinated way. Otherwise, I think we're all going to be sitting here with a couple of successful operational projects, a couple of successful drugs, nowhere closer to having Lusaka having drugs on the ground in the clinics in the foreseeable future.
Thank you, François. One burning question from Nyeko, very short, to François.
Thanks so much, Prof. I just wanted to ask around what are the setback implications related to the licensing of the products. For example, the delays around voluntarily licensing of cabotegravir from the manufacturing company so that we can have full access to the other low and middle income countries. Thanks.
So I'm not totally clear on why there were such big delays. Talking to the company initially, Vive initially said we are able to make sufficient for all needs across the world. And it became very apparent to us as the negotiations went along that they said we're not going to license it to the generics. That was my understanding. And then when it became very clear they couldn't manufacture enough for the needs of everybody, that they then started the process of licensing. And that process has only just happened in the last 2 or 3 months. Now, from that period, now the generic companies have to go and buy very expensive equipment. They then have to do quite expensive studies, which take up to 18 months to 3 years. The process has only started now. So we've got a 3-year timeline from now, from the time that the generic companies now start the registration application processes. So you understand why this is such a disaster in terms of cabotegravir and the processes. No one seemed to think that there was this TikTok thing happening. There's a timeline from the first time that we heard that cabotegravir was successful for PrEP, which was in 2020 already, in early 2020. So if this whole process happens, we're going to be lucky so 4 or 5 years' time, plus from 2020, that's 8 years. We got tenofovir faster than that, and that took a long time. So it, again, just suggests to me there's no joined-up thinking in terms of everybody thinking. We do a study and we show success. What are we doing about making sure that the people we're doing the studies on are going to actually enjoy the benefits of it? I'm not blaming anyone. I think this is actually a very complex area, but I do think it needs to be a bit more coherent next time around, and we need to start thinking about it now.
Thank you. I think one key word is advocacy. It's needed, and let's just give a round of applause to our 2 presenters. Thank you.
Thanks so much for the key presentations. Now we are heading to the abstract presenters. Allow me to introduce Minh Nguyen, all the way from Vietnam. Minh will be presenting under the title of HIV Testing, PrEP Awareness, PrEP Uptake, and Correlates among adolescent men who have sex with men in Vietnam. Oh, the presentation is virtual, so...
Hi everyone, my name is Minh Nguyen and I'm currently a lecturer at Hanok Medical University. I apologize for not being able to attend the conference in person today, but it is my pleasure to present to you our research titled HIV Testing, PrEP Awareness, PrEP Uptake, and Correlates among Adolescent Men who have sex with men in Vietnam. And here are my colleagues who also contributed to this work. So compared to older men who have sex with men, or MSM, younger MSM usually have lower self-perceived HIV risk, but more risk behaviors for HIV infection. They also face unique challenges to HIV prevention and care due to the lack of comprehensive sexual education, lack of family support, and legal barriers due to the young age. In Vietnam, recent data show that 12.4% of young MSM under 20 is HIV positive. We also know that pre-exposure prophylaxis, or PrEP, is a powerful tool to prevent HIV infection among MSM. However, little is known about the prevalence of PrEP awareness, PrEP uptake, as well as HIV testing among adolescent MSM in Vietnam. We conducted this study with two objectives. First is to assess HIV testing, awareness, and uptake of PrEP among adolescent MSM in Vietnam, and second, to identify factors associated with these outcomes. From November 2022 to April 2023, 120 adolescent MSM from 15 to 19 years old in two largest cities in Vietnam, Hanoi and Ho Chi Minh City, were recruited through peer outreach. Inclusion criteria included being 15 to 19 years old Vietnamese, being born biologically male, having had sex with another man before, having a negative or unknown HIV status, and living in these two cities. We excluded those with known HIV positive status or unwilling to provide informed consent. Participants then completed an online survey, which include questions on demographic, sexual behaviors, HIV risk perception and knowledge, HIV and STI testing, excuse me, as well as PrEP awareness and uptake. We use multivariable models controlling for confounders to determine the factors associated with HIV testing, PrEP awareness, and uptake. We also calculated prevalent ratios, and confidence interval. Moving on to the result, as you can see here, the large majority of participants have heard of PrEP before, with only 18% have never heard of PrEP. However, when it came to using PrEP, only 37% have ever used PrEP before. And there was still a large amount of people who have never tested for HIV, which is 42%. As for lifetime HIV risk perception, we can see here that a large majority thought of themselves as having a low risk or even no risk of HIV infection during their lifetime. So the two low risk categories added up to 80%. Also, no one chose the highest category of extremely likely. This table showed results from the multivariable models exploring the association between participant characteristic and HIV testing, PrEP awareness, and uptake. There are blank spaces here because if two variables were not associated in the univariable model, we did not include them in the multivariable model. And all significant association were highlighted in red. The first thing we noticed was that compared to those who think they have some HIV risk, those who thought they might not get HIV at all are actually more likely to have had HIV testing and use PrEP. This might be it's HIV testing and PrEP uptake that made an impact on people's risk perception. So those who already had a negative HIV test or used PrEP before might be confident that they can be infected. Moreover, HIV knowledge was associated with both HIV testing and PrEP awareness, but not PrEP uptake. We also found that those who had an STI test were more likely to have an HIV testing and know about PrEP. And finally, having had sex with another man was associated with HIV testing. So to conclude, HIV testing was associated with HIV knowledge, lower HIV risk perception, STI testing, and having had sex with another man. But only HIV knowledge, STI testing was associated with PrEP awareness, and PrEP uptake was only associated with low HIV risk perception. And even though a majority of adolescent MSM in Vietnam have heard of PrEP, HIV testing and PrEP uptake was surprisingly low. We recommend that qualitative research exploring barriers and facilitators of HIV testing and PrEP uptake is necessary to provide a deeper understanding of this behavior. and future interventions should also aim to increase HIV and STI knowledge and exposure to testing services to promote PrEP awareness and PrEP use among adolescent MSM. Thank you for your attention.
Thanks so much, Minh, for the insightful presentation. I hope you are preparing your questions because time is not on our side. And then allow me to also introduce MaryJane, all the way from the United Kingdom, under the title Designing Innovative HIV Prevention Interventions that are Acceptable to Adolescents in Sub-Saharan Africa, Insights from a Mapping Review and an Inductive Thematic Analysis. All the best, MaryJane. Oh, it's a virtual presentation.
Hello, everyone. My name is MaryJane Nweje. I'm sorry I'm not able to be there in person with you, but I'm very excited to be sharing our work with you today. Our research is focused on designing innovative HIV prevention interventions for that are acceptable to adolescents in Sub-Saharan Africa. This is the outline of the presentation. The research was conducted in the Accelerate Hub, a research consortium led by the Universities of Oxford and Cape Town, focused on identifying interventions that promote multiple outcomes for adolescents. Research has shown that adolescents and key stakeholders' acceptability of HIV prevention interventions is crucial for designing innovative, evidence-based, scalable interventions. Higher acceptability can improve the uptake and effectiveness of these interventions. So in our research, we set out to explore the research question: what do young people and key stakeholders find acceptable and unacceptable in HIV prevention interventions? We conducted a systematic review, and through the in line with the PRISMA guidelines, we identified 32 studies assessing HIV and the acceptability of HIV prevention interventions between 2010 and 2022. We then conducted a descriptive synthesis to identify and highlight key study characteristics, and then an inductive thematic analysis to identify the reasons for acceptability and unacceptability of these interventions. There are 32 studies that are located across West, Southern, and East Africa. So the stakeholders that were identified across some of the studies include parents and caregivers, teachers, healthcare workers, and policymakers. And these are the interventions whose acceptability were assessed across the different studies. You can see there's a range of interventions, HIV prevention interventions. And to highlight some key acceptability findings, overall, the acceptability of these interventions were high. 12 studies assessed prospective acceptability, that is acceptability before receiving the intervention. 10 studies assess acceptability, concurrent acceptability, that is acceptability while receiving intervention. 6 studies assess acceptability retrospectively, that is after receiving the intervention. And 4 studies assess acceptability at different stages of the interventions. In total, there were 32 studies that assess acceptability of the HIV prevention interventions by the adolescents and young adults. And of those 32, 14 studies also assess the acceptability of stakeholders. Using the inductive thematic analysis, we've identified 7 key factors or themes that were explained acceptability of these interventions by both adolescents and stakeholders. And these include ease of the use of interventions, intervention understanding, intervention cost, perceived positive and perceived negative effects, relevance of the interventions to adolescents' lived experiences, and social factors shaping acceptability. Now, these are the 7 themes, and some of these themes also have sub-themes. Just to highlight some key thematic findings. So both adolescents and stakeholders highlighted that the intervention's relevance to their lived context was a reason for accepting an intervention. And in the opposite frame, adolescents and stakeholders highlighted that perceived negative effects was a reason for not accepting an intervention. To highlight some key gender findings as well, female participants highlighted opportunities or for autonomy as one of the reasons for accepting HIV prevention interventions. So in conclusion, some key messages. Acceptability of HIV prevention intervention by adolescents and stakeholders is critical if we're going to be designing innovative HIV prevention interventions moving forward. There's therefore a need for youth-led and youth-informed HIV programming more broadly. The young people find these interventions acceptable. However, there are various interrelated drivers of the acceptability and unacceptability of these interventions, and we need to pay attention to these drivers in the designing, in the implementation, in the decision of scale up of these interventions. If we're going to be designing innovative and acceptable HIV prevention intervention, we will require attention to these several dimensions, because whether it is cost, whether it is concerns about negative effects, whether it's side effects, whether it's stigma, all of these determine whether an adolescent or a stakeholder will accept a HIV prevention intervention. And finally, our research also highlights some critical areas for future acceptability research. So there is need for exploring the difference in the acceptability of this intervention across the spectrum of adolescents, whether it's across the gender spectrum, the age spectrum, context, location, as all of these also determine the acceptability or unacceptability of these interventions. There is need for further investigate the acceptability of combined HIV prevention interventions, the packages which are quite popular. And finally, there's need to further conceptualize the construct of acceptability to develop a more robust frameworks and measurement tools so that we can adequately and effectively assess intervention acceptability. Thank you for your attention.
Thank you so much. Our two abstract presenters are online and would like to get a few questions for them. There's a question.
Hi, Anna Puga with Vive Healthcare. Great presentations. I just wanted to clarify a little bit of the timeline around the voluntary license. I heard there was a question right at the end of François' presentation. The cabotegravir approval occurred in December of 2021, and within 7 months, Vive Healthcare signed the voluntary license agreement with MPP. And within 8 months of that, MPP has selected 3 generics as of March of this year, Aurobindo, Cipla, and Viatris, to produce cabotegravir. I don't disagree with a lot of the coordination that needs to continue to happen to make sure it gets implemented in the ground everywhere and is accessible to all who are at risk for HIV. So I just wanted to make a correction on that timeline. Thanks.
Thank you. Again, the institution you're from? Viv? Oh, thank you. Are there any questions to... The mic is coming.
I am Precious Kaniki, and I wanted to ask the professor, since he's here. I wanted to ask when you talked about the injectable drug, lenacapavir, which is supposed to be taken once daily. You also mentioned that it is to be taken with highly experienced patients. Been living with HIV for more than 16 years. I don't know what you mean when you say highly experienced patients. And another comment maybe can be on PrEP, since you've mentioned that there is no coordination on most of institutions, and it seems PrEP is a failure. Why don't we look at other measures of advocacy? We can talk about You Equals You. I think if a lot of people know the importance of being undetectable, suppress their viral load, we are talking about least transmission. I personally think we can take You Equals You to more higher level and to see how the infection, if can be decreased.
That was more of a comment. And I think, François, do you want to react?
I did want to ask the VIV as a contribution from, like, I accept all of those comments. What I would ask is, at which point was the text transfer in the hands of the generic companies? At which point are those 3 generic companies assuring us that they are actually going to manufacture the drug? I know that's not VIV's responsibility, but for us on the ground, that's all we care about. And we haven't had that assurance yet that they are actually going to do that.
Thank you for that. March 2023, the 3 companies were selected after a selection process, ensuring they had the technology on the ground to produce the drug.
But have they confirmed that they are going to produce the drug? I'm saying that those are 2 different things, because we have had word that they may not actually produce the drug. They're going to just sit there and wait for lenacapavir because that's the way things are.
We have not heard that. To my understanding, they have made the intent to produce the drug.
One quick question. I hope we have a question for the abstract presenters. Yes, please go ahead.
Hello, my name is Hope Banda from Malawi. My question goes on PrEP. I'll take the example of the young people who take ARVs. Most of the young people are taking ARVs. They say that they should take every day. So once they default, there's a tracing way where they go and trace the person who has default from taking ARV. So concerning about PrEP, what intervention are you targeting on once a person has stopped PrEP? What intervention are you taking? Because once they go to the hospital, they say you have to test for HIV. When they are negative, they are given PrEP to go and check it. And they told them that once you finish taking the drugs, you have to come back and test again. So my question is on when they go to take their PrEP, they default on it. So my question is, what intervention are you getting to trace those people who have default from PrEP in order to go back to the hospital and be tested again to find out if they are HIV positive or HIV negative? Thank you so much.
Thank you. Minh, did you get that question?
I'm here. I think the connection was not very good. Like, would you mind just like briefly like rephrase the question, please? So I heard that like if one person does not take PrEP, then what it's the next intervention for them? Is that correct?
Okay, all right. So it's for us or what? Yes.
Yeah, so I would just take the first step to answer the question. Can you all hear me?
It's for PrEP defaulters. So what interventions do we have for those who are defaulting PrEP?
Yeah, that's a great question, and I think that's the problem we have a lot with young people. Because like they, for example, from the study that I just presented, we also have a qualitative component that found like many different barriers with PrEP. So I think the ultimate goal is to help them, like to prevent them from getting HIV. And I think PrEP is still like a very effective way, and it's been proved like through evidence-based intervention. So I think the next step that should be done is to understand why they don't take PrEP. It's not like remove PrEP as an option, but like explore more like what are the barriers. So for example, if they live with their parents, that they don't want to reveal that they're taking PrEP, or if they're the clinics that they need to go to is too far away and they have school and they have other responsibilities that they can't go to take PrEP, then our role as researchers is to find out what are the difficulties that prevent them from getting PrEP, and then creating new strategies and solutions to help them address those barriers. Yeah, I hope that's answered the question.
Thank you, and we have a comment from Wawira. Please go ahead. And also a clarification, Wawira. You needed to make an additional. Yes.
Okay, thank you. I just a small update, and I know François talked about the challenges we're having with coordination, but I just wanted to reassure this room that it's not all doom and gloom. And there are a lot of efforts that are being put to make sure that we are addressing some of those issues that are emerging, including pricing. So there is a group of conveners that comprises of UNAIDS, WHO, Global Fund, PEPFAR, UNAID, and UNITAID, and AVAC is the secretariat. And what this team is doing is that they've come together and they are building on the lessons that we've learned under oral PrEP. We did a lot of mistakes, and we do not want to repeat the same with the products that are coming in. And some of the things we are doing is we jointly try to identify some of those potential barriers that might be a hindrance, including volumes, prices, how best to engage the community. And we are engaging with the product developers for the 3 products right now. We've been having conversations with Viv, Gilead for land that is coming up, and also Pop Council on DVR. And so just to ensure that these issues are being addressed, and we've made an extra effort to make sure that we are bringing on board the advocates, and we do this through the advocates caucus, and also working with the donors to look where they can also help through a donor caucus. So I just thought I should share that with you, just so that you don't get very discouraged. Something is happening. We are not yet there, but then effort is being made. Thank you.
Thank you so much. We've come to the end of this session, but before we leave this room, Professor Linda and the young people have a plan for us in terms of advocacy. Prof.
Question from Pablo about what are we doing as a community, and to Wawira's last comment, we thank AVAC, and we're obviously very grateful that there are some efforts. I think though maybe there are some key questions that this room can raise, and here I want to sort of put my historical old hat on. Way back in 1994, there was a thing called the Denver Declaration that came about, and that said, every time we gather in the name of HIV, somebody living with HIV needs to be involved. So the GIPA principles came about way back. And we stood by that, right? Because the community came out and said, our voices must be heard. Who was alive in 2000? Okay, I was alive in 2000. We had a Durban Declaration, which was so important. It said, all the drugs are in the north, none of the drugs are in the south. The people in the south are dying. Do something about it. And that was very important. It was a turning point. We subsequently had very important declarations. What my colleagues here have said, is there not an opportunity for us, for this room, to make a declaration about the need for those long-acting interventions for us here today as soon as possible? And we understand these things take time, but our governments, PEPFAR, Global Fund, UNITAID, UNAIDS, our moms, our dads, the community at large, the doctors, everyone needs to hear that we want these drugs sooner rather than later. And I remember, Demaris, 7 years ago we sang that song, and we were very hopeful and very excited, and we remain hopeful and excited, but we need to rally. And so we would like, those of you who are interested, and I'm hoping it's mostly going to be the young people in this room, to gather around us so that we can come up with that Durban Declaration. And we understand it isn't just going to be demands, it's about what we believe needs to happen. We want the world to hear that young people, as well as those wonderful women who put out the manifesto for choice, we also believe that choice is going to revitalize our lives. Not only those of us who have lived with HIV, and I want to answer that question, you are the most experienced individuals in the world. But I think what François was referring to in the terminology of experience means people who've used a number of different antiretrovirals and so have had a lot of different types and classes of antiretrovirals. We were discussing this terrible terminology of salvage therapy. We think it's time for a new name for people who need to go into new ways of being treated because either they have been exposed to a lot of different drugs or the kind of treatment they've got today just doesn't work for them. And it's time to try another treatment. I know Natella's going to lead that. Okay, so back to long-acting interventions. We really want to see a declaration come out of the 7th Adolescents and HIV workshop. How do people feel about that? Cool. So it really does need to come from people who are very much younger, about a, third of my age, if not younger, a quarter of my age and younger. But I and others will help to make sure that it's crafted in such a way that it has an impact, and then we will help you get this to the places where it needs to go to have an impact. Okay, so that's the pact. All right, so maybe after this we can just gather and get together around a way forward. Thanks very much.
We have, for Zambia, one of our policymakers and the team who is a mayor, and they have been championing the fight against HIV and also the adolescents. Who would like them to join your group? Please come through. So we need to also have these policymakers, the civic leaders, to be involved in that, and just a word, and I think join the team as part of this declaration.
Great. All right.
Thank you.
Fabulous. All right, we'll be here.
Thank you.
Thanks, Lloyd.
We are reminded that we have an online survey which should be sent by email. So let's do that.
And then there are also guided posts. There's a guided poster tour on the, what is it called again? Emalini room. And then please go there and, the abstract presenters will guide you. The abstract poster people will guide you on what they've developed and all that. Thanks so much for your participation, and thanks so much for a high level of engagement on the workshop. All the best.
Thank you. Alice, over to you.
All right, we couldn't let this moment pass without recognizing the leadership and the contributions of our amazing Professor Linda Gale Becker. We just wanted to take this moment to thank you for your openness, your drive, your enthusiasm, your activist heart, your commitment to evidence, and your friendship over the last 7 years that is this workshop. And even after being the co-chair, here you are, doing amazing presentations, encouraging us and leading us, and we can't thank you enough.
So we wanted to say on behalf of the organizing committee, the youth reference group, and all the participants and attendees from the very first workshop to now, and the ones coming in the future, that you continue to inspire us. We're deeply appreciative and thankful for all your work, and we look forward to engaging with you more and having you continue to inspire us and guide us to a bigger, better HIV and adolescence workshop. So thank you so much. I think we had a little bit. Yeah.
Thank you. We can go for the guided tour of the posters. Thank you.